Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist, and I serve as the Chief Physician Executive of Houston Methodist. Join us each month as my guests and I discuss the many ways that quality impacts care delivery. Today, I'm delighted to welcome Dr. William Cooper. He's the president of Vanderbilt Health Center for Patient and Professional Advocacy. His research explores how professionalism impacts quality and patient safety. Welcome, Dr. Cooper.
Thank you so much for having me.
All right, Bill, so tell me about this institute or center that you're leading.
So we've been at this for about 30 years at Vanderbilt. We started as sort of a shop that was looking at medical malpractice risk and why doctors get sued. Some get sued more than others. And then we learned in our research that sometimes the ways that physicians interact with their patients are leading to their increased risk for being sued, because about 2% of doctors account for 50% of malpractice claims.
2%. So only 2% are sued? Because when I was a retina fellow, they told us, your chance to, or likelihood to be sued in a lifetime is like 95%. I remember that because it scared me.
Individual physicians may have malpractice claims, but 2% account for half of the overall claims by specialty.
Okay.
And so those outliers are also the same people who in our early research got a bunch of patient complaints. And so when you look at the list of patient complaints and you look at the list of malpractice claims, those top people are the same.
Okay, so you lead that. The institute is there, or the center is there for 30 years.
Yes.
You lead that for the last 12 years.
For the last 12 years.
How did you get there? Tell us about yourself.
So I'm a pediatrician, so I take care of children in a primary care clinic at Vanderbilt. And as I took on leadership roles, both within the Department of Pediatrics as well as at the health system, I was trained as a part of our teams that share feedback to those individuals who are at high risk for malpractice claims and complications. So they asked me to look at that job about 12 years ago, and I took it on, and it's just been an amazing journey. So
12 years ago, you take over as the leader, and then what do you do?
So as an epidemiologist, I was interested in other ways, because our early work was in medical malpractice claims. And what we found is that if you give those docs feedback about their patient complaints before they get sued, you can actually reduce their malpractice risk by about 80%.
So how is that? Give me a story or an example.
It's peer-based feedback. So if we have, and I sort of shared these messages at Vanderbilt. So one of my colleagues may have a bunch of patient complaints and they show up. We're able to benchmark with our data set. We're able to benchmark and say, gosh, when we look at other cardiologists, for some reason your practice is different. And so we can show them on a curve that out of 1,500 cardiologists, they're number 2 nationally. And that light bulb moment for them when they're sort of naturally saying, well, my patients are different. I'm at a really fancy place and I've got all these things. I'm like, well, yeah, but other people who practice in these same high profile places don't have this. And I just thought you'd want to know.
So interesting. So how do you get these patient complaint national database? How is that available?
So our center, we started and we started doing this. We did a randomized controlled trial to show that it works, and it does. And then what we found is that as people saw our favorable experience, both in professionalism and malpractice claims, they started knocking on our door. And so now we have this national collaborative of about 300 hospitals here in the U.S.
300?
Yes, and there's another 200 hospitals or so in Australia, New Zealand, and Singapore who use our approach. And we bring our domestic, our U.S. hospitals, send us their patient complaint data, as well as their safety event reports about unprofessional behavior towards colleagues. So 2 programs, one for patients called PARS, Patient Advocacy Reporting System, another called CORS, the Coworker Observation Reporting System. And we identify those individuals who are outliers and then have peers, not their boss. Peers have those conversations.
Wow, this is a lot to think about. And I know that myself, I'm not familiar with it, and our listeners might not be familiar with it. So how do you, first of all, many questions, but how do you have a way to approach that physician who may be, a super famous, world-renowned surgeon, for example? How does someone approaches that person? And then how do you provide feedback? And then how do you see this turnaround?
So it's really important that we assign peers to peers, right? So as a pediatrician, if I go in to talk to a surgeon, their first question would be, well, what do you know about surgery? All right, and so we assign sort of peers based on their experience as well as their specialty focus. But then that peer conversation is we train them for 2 hours on how to be respectful, non-judgmental, and most importantly, not to fix it themselves. So I know if you get patient complaints, Shomit, about sort of like your patients feel like you're dismissive because you have your hand on the doorknob during all the visits and you feel rushed and they're doing all stuff. And I say, well, what you need to do, just take your hand off the doorknob. If I give you the solution and it doesn't get better, what are you going to say to me?
It didn't work.
And I did what you told me. And so our peers are trained to have the conversation to just say, I don't know why this is, but for some reason these data suggest this. And as your colleague, I thought you'd want to know.
Interesting. And so people accept it.
They do. They're not always happy, right? But feedback is hard sometimes. And so they may not be thrilled. I've never had anybody jump up and sort of thank me for having this conversation with them. But what they do is they turn their careers around.
So you said respectful, non-judgmental, and then don't fix it. What is respectful? How do you approach?
I might, if I were having a conversation with you, let's say that you had on the coworker side an interaction in the OR with a surgical tech that just didn't go right. And I might say, Shomit, gosh, tell me how your day's been. I just want to check in with you. And we'll talk a little bit about that. And I'll say, yeah, I get that. Sounds like it's been kind of stressful. Now, tell me a little bit of how yesterday went on in your OR block time on, Monday morning. We'll talk a little bit about that. And I'll say, yeah, well, I'm a part of the Professionalism Committee here, and we did get a report about an interaction that you had. And sounds like that one of the first cases of the day started, and the surgical tech handed you an instrument or something just didn't seem to go right. And the report said that you turned to them and said, do you hate your job? Because you just do it so badly. Tell me about that.
Wow. And then the response that you get.
In the response, they'll tell me all the reasons why they did it. And I'll say, yeah, I get that. Sounds like that was a really challenging interaction. Now, Shomit, I'm just wondering, next time you're in the OR, is there any way that could go differently?
That's it.
That's it.
Okay, you don't tell them how.
Don't tell them how. 97% of the time for those single events, it does not happen again.
Interesting.
It's fascinating. And we do this work with physicians. We do this with APPs. We do this with staff nurses. We do this with surgical techs and MAs. And I have peers in all those spaces. But when you have that conversation that just says, I care enough about you to try to help you be the best version of yourself.
Amazing. I care about you, and that's why I'm telling you and giving you this feedback. I'm not just the feedback, but you have to figure out what you would do differently next time.
Absolutely.
I'm not going to tell you.
It's about self-regulation, right? So when I, in my pediatric practice, new antibiotic prescribing guidelines come out for pneumonia, right? I'm here prescribing some fancy high-cost antibiotic, and the guideline is here. What do is self-regulate. And it's that self-regulation that we believe is the secret to people's, because once they change, we had 25 years of follow-up data. They stay good.
So were you able to decrease the amount of claims and suits?
We published a study just last year, actually, looking at a group of orthopedic surgeons where we measured their claims risk before they got the interventions and after. And we also measured the entire groups. There's about 260 surgeons in this group. We measured the group's risk. And what we found is that we were able to drop their malpractice claims risk by 83%.
Wow, that's amazing. And that's also, it warms my heart, because that means that people are treated more respectfully in the workplace, and our patients are getting kinder treatment. So that's wonderful. Tell me about the specialties, the different specialties that are more prone to get this kind of consultation and help.
In all of our work, no offense, as a surgeon, I will tell you that surgeons are at greatest risk to have professionalism concerns really across the board. Within surgical specialties, there are some differences, and we're doing studies in that space now. But
so what is the most high-risk specialty?
Probably, so in terms of malpractice risk, obstetrics and gynecology really sort of sit out there. Orthopedics and spine surgeons often will have greater risk for malpractice. That's been shown for years. We've done some work in ophthalmology showing differential risks for early in your career for having professionalism concerns that then sort of gets better as you get more experience in your career. And when we look at the coworker concerns, what we find is that surgical specialists as a group are more likely to have those concerns. Then the next group is proceduralists, those like cardiologists and pulmonologists and gastroenterologists who are non-surgical but do procedures, and then emergency medicine physicians. And then sort of primary care physicians, internal medicine physicians, and others are sort of at the lower risk for that.
So why is that?
Well, I'm a pediatrician, so I believe that pediatricians are kind, right? And so I chose to go into it because they're kind.
Because you're kind,
right?
You went to it, and that's it, you remain kind.
And I love my job. I love taking care of children. And so that sometimes the people that go into those specialties, it's also, there's different risk and different stressors, right? So I get it. Like doing a retinal case, there's a lot of stressors that need to go precisely right at that moment in time. As I've worked with my surgical colleagues over the years, I've also learned that oftentimes surgeons are acculturated to say, you and you alone are responsible for the life and death of your patient. There may be anesthesiologists in the room, there may be circulators, there may be techs, there may be all sorts of people, but you are responsible for that. And that response, then, so when a tray comes up that has stuff on it or they don't get the case started on time, that's not just frustrating, it's actually an existential threat to your career. And so people that haven't figured out how to navigate that stress often will have these really strong responses.
Yeah.
So what we have to do is help them understand that when you do that, when you scream and throw stuff, people get paralyzed. So studies have shown that people don't pay attention, they don't communicate, and they don't ask for help.
So, what I'm curious about, you said about self-selecting, this is one, but then you come to an environment, I'm a retina surgeon, I watch my mentors and my, colleagues, and then I watch my residents and fellows do surgeries. And I think that part of me is shaped by what I watched and, who I want to be like or what I see as necessary to be like. So what part the environment plays a role? It's not only you, it's the environment that you're in.
Such an important part, that environment, and our mentors really influence who we become. I can think of mentors who were such positive role models for me, and I try to emulate them in what I do. But you also see, I was talking actually recently with a surgeon who said, when I was in medical school, I was really drawn to surgery, and I told myself, if I'm going to be a really good surgeon, I'm going to have to learn how to throw stuff.
Interesting.
And what a challenging existence that must be.
Yeah, this is not recent, I hope.
This is years and years and years ago.
Okay, good.
That this occurred. But as we were talking, the surgeon said, but you know what? After a year or two, I learned that when I did that, the entire room got paralyzed. Nobody did anything because they were so put off trying to avoid having that negative thing happen.
Yeah.
And they turned their career around to approach things in a totally different way.
So do you see your work or your team's work as changing the individual or actually changing the environment?
It's both. What we find is that when we talk with nursing leaders about sort of what happens when we address physician behavior or even nurse behavior, they'll say, I've had nurses who used to call out sick because they knew that on that shift they were going to be in the ICU with Dr. So-and-so.
Oh, wow.
And they would not come to work for their own well-being. And they tell me that now that they've gotten this intervention, they are behaving better and they don't call out sick anymore.
So you go to you're here in Houston today. You went to one of our sister hospitals,
Yes.
or kind of a competitor of ours that we're not going to mention the name. But how do you work with other institutions across the country?
Part of that is that in our work with them, we really support in the back end a lot of their work. So we come inside and we train their leaders. We train peer nurses and physicians and advanced practice professionals how to have
Together, or how do you train?
We train them together because that's really important. I need to have a nurse in the room with the doctor to understand what professionalism looks like across all professions.
So you train, you were here in Houston and you trained a group of people. So how does it look like? Tell us.
So we'll sit and we'll say, we tell them why this matters, because what I've done in my research since I took over is that we've actually been able to link these behaviors to complications, burnout, difficulty with personal relationships, cognitive impairment. And so now, in addition to malpractice, we know that if you behave in this way, your patients do worse.
Yeah.
And so we teach the foundation of that so that as they're going, it's hard to have these conversations. So I need to get them over that that hump of saying, okay, I get why I should do this.
So you're teaching these group of people, interprofessional, right, to talk to a specific physician or surgeon that you think is at risk of being sued or has multiple complaints and is an outlier in comparison to their peers. So you target your intervention to the individual. Does anybody know in their team that they had that intervention, or this is completely confidential? How do you change the environment if you just targeted the individual?
There's really two ways. One is, I don't go out and say, I just really had a really stern conversation with Dr. So-and-so. I need to respect their privacy and their confidentiality. Yes. But what happens is people see that they start behaving better. Mm-hmm. And so that's how you get psychological safety, because they're no longer screaming. And
so one conversation is enough to change the habit? That's amazing.
You would never believe it. When we started this, one of our senior leaders at Vanderbilt said, this is such a weak intervention, it will never work. Huh. So that's why we did the randomized controlled trial. And then we continue to show differences so we can we'll track people's progress. So when you get a pattern, so if you're one of these on let's say the coworker side, you have multiple reports about how you interact with nurses and other physicians and APPs, and you are an outlier. You're in the top 2% nationally for your specialty. If I show you those data, 88% of the time you stop doing it.
Interesting.
Even when you've done it multiple times.
So interesting. So, I hear from our patients, and I see it in our patient responses about how the care was. The number one complaint that people have, if they have a complaint, is that I didn't feel that my team was interacting and they all were not on the same page. And so I felt that Dr. So-and-so is separate from Dr. So-and-so, separate from the nurse. So when you talk, I'm thinking, you target a person and you target them because they got complaint. But how might we train everyone to speak with respect to each other and also to communicate in a way that the patient feels that we are on the same page? Have you thought about that? Are you doing some of this?
We think a lot about that. And because part of that is that I want to create a culture, really at every place, a culture where we talk with each other and not about each other.
Yeah.
How many times do people go to the surgeon's lounge and talk about other people? And how many times do the nurses go to the break room and talk about doctors or other nurses? If we could just have the courage to talk with each other in the moment. And so a lot of what we do with our onboarding is to say, we are guided by our values here. You've got the eye care values here, right? Amazing thing. What amazing place. And so when you think about the eye care values, part of that is respect.
Right.
And all that, and so that idea is like, I want to be the best version of myself. Mm-hmm. And so if for some reason we have an interaction that doesn't go well, I should pull you over to a private space and just say, gosh, you know what, when we were just talking about, I asked for that consult on my patient, and it sounds like that you were really reluctant to do that. And, all my residents saw that interaction, and anybody that could
So do you train people when they on board?
Yes.
I mean, how do you do that?
We train all of our new leaders. I've probably trained 1,000 people at Vanderbilt on how to do this.
To have that conversation.
To have those conversations.
Is there a name for the conversation?
It's called a cup of coffee conversation.
A cup of coffee. Why is it called a cup of coffee?
It's called a cup of coffee. It's our basic conversation for single events. And the idea is I want to make sure that people get that it's informal. Mm-hmm. It's not a formal thing. I'm not having a performance conversation. I'm just saying, gosh, let's share a cup of coffee. It was sort of the idea, sort of the metaphor for it. But it gives you a chance to say, wow, let's just talk about this.
Interesting. And this cup of coffee concept has percolated over the country and also the world. You're saying that you have international places.
UK, Canada, Australia, New Zealand, Singapore. And so being able to help people, because what I love doing is helping healthcare organizations and people be the best version of themselves.
So I'm very curious because I lived in several countries and states, and cultures are different. So how difficult it is for you to train people, let's say, from Singapore?
Right.
I mean, the different culture, right?
Totally different hierarchy. Because what we do is when we start working with organizations, we make sure we understand their culture. When I walk through the lobby of your hospital, this is an amazing place.
Right.
U.S. News and World Report, like you all are unbelievable in your commitment to quality. That tells me what I need to know about you. So when I'm saying, gosh, you know what? If you want to be the best version of yourself, this is getting in the way of that last little frontier. And so helping them understand that, and then they understand, because I train local people, they know the culture to deal with that. And I can't tell you how many times people have said, well, you know what? You've done this in the South of the United States. You don't really understand New York. Like, people are different. Or you've done this in the United States. You don't understand Australia. And I say, well, okay, tell you what. Let's look at your data. Because our distribution is typically that 90% of people never have any single event ever. 7 or 8% may have a bad day, stub their toe. 3% account for the sort of the disproportion, about 50% of the disturbances, as we call them. So I took a Nashville curve, I took an Alabama curve, and I took a New York City curve.
Yes.
And I put them up on the wall, and I said, which is yours?
And they didn't know?
They couldn't tell.
Is it different? The curves are different?
No,
now?
they're exactly the same.
Okay.
It doesn't matter. And so, I joke about pediatricians. We may not be aggressive, we're just passive aggressive. So my behaviors get in the way, if I'm not careful, of what that is. I'm just not throwing and screaming.
And tell me, the physicians, that's a very curious question that I have for you. The physicians that get the complaints are maybe sometimes from different cultures completely? Occasionally
they are. And so like learning how to sort of navigate complex interactions. So we don't see a statistically significant difference. But certainly there's times where just understanding that, and I like to think about viewing my interaction with a patient through my window, but if I don't recognize that they're viewing their interaction with me through their window, I miss an opportunity for respect.
Yeah. So, it's the reason that I'm asking that is obviously I was not born in the United States. And I realized that the way we even dress as physicians is different in my home country than in the United States. And since then, every fellow that I had or every resident that I had that was international, I said, if you're a doctor, you wear a tie. That's a symbol that you're a doctor. I understand that in your home country, you wear jeans and a T-shirt. That's what I used to wear.
Right.
But here you dress up, and that's how people know that you're a physician. So it's very interesting that, sometimes people may get complaints, but they're actually not aware that something about their behavior or the culture that they bring with them is maybe not acceptable in their new environment, and then they are more likely to get into troubles.
And that's why we're there to help them understand. Because if they don't respond, let's say 88% respond to that pattern, like they've got multiple reports. If they don't, we keep moving up on what we call our pyramid. So the cup of coffee is the base of the pyramid. That's
that's the base. Then you said 97% change. Okay.
And if you move up where you get a bunch, we call that an awareness intervention, because I want to make you aware of this pattern. But if that doesn't work, now we're down to about 0.5%. Then the tiered intervention kicks in, where your boss is going to have a conversation with you about improving your performance.
Do you teach bosses how to talk?
Of course, right? Did you ever get a job because you're really good at accountability?
Right.
So that's the thing. It's like,
so I have to have difficult conversations all the time. So can you
stressful.
teach me how to have them better?
Absolutely. So here, what I would say is that, like, if you're going to have a conversation with me, you would say, Bill, gosh, our expectations here at Houston Methodist, are that we treat each other with respect. We're guided by the eye care values. And that's such an important part of what we do in the Department of Ophthalmology. Let's say you're my chair. Now, we've talked before about some interactions you've had that just weren't consistent with that culture. And I'm sorry to report that now there appears to be a persistent pattern. And what we're going to do is put in place a performance improvement plan.
Mm-hmm. So basically you're saying our expectations are here.
You're
performing there, and this is how we're going to close the gap.
And I further go on to say, if it's a medical staff action, I may use a medical staff action. If it's an employment action, I may use a performance. Whatever that is, as a leader, I've got that. But I'm going to say, I need you to understand that I expect this is going to get better, because you're an outstanding member of our department. But if it doesn't, we may have to take other actions.
Interesting. And so eventually there is a very small percentage that does nothing help, and then you have to let them go, I guess.
We have tracked 160,000 individuals in our database. There are 400 that haven't responded. And of those, 5 had previously undiagnosed brain tumors.
Oh, wow.
20 had cognitive impairment and other challenges. And so if they don't respond to these interventions, it may be that it's not that they won't, it may be they can't.
Uh-huh.
So we have to engage them.
Yeah, I think, as a physician, this speaks to me. Sometimes you can't, and then there may be something underneath that you need to really help. And maybe the help is you can't do what your job says you do. Like, you can't be this leader or this surgeon. Maybe you should do something else.
Yeah. And the good news is that when we start low, we can actually prevent it. We do this with our trainees. So if you start someone in their career and address challenges that they have early on, there's an 87% chance they will finish their residency and not have other professionalism concerns.
So are the claims rate nationally decreasing thanks to your effort or not?
There's a lot of market forces at play in that, right? So we can't claim all of it, because what we're doing, we are reducing. Organizations find that they do drop their malpractice as an organization because your highest risk docs are no longer getting sued.
Okay.
And the coworker side identifies, interestingly, another group that's at risk, but it's different people. Have you ever run into a narcissist in your career yet?
Yes.
Of course, right?
Yes.
So the narcissist spends their days saying, great news, I'm your doctor, Dr. William Cooper, and I am such a great doctor that I saved your life. Now, when you come for all your follow-up, make sure you come to see me, because my partner, they're an idiot, and they will kill you and undo all of my hard work.
I heard actually people say that.
Oh, they do it. And the narcissist doesn't get patient complaints, but people, it turns out, don't like to be called idiots, do they? So they get coworker concerns. So both of these programs allow us to have, opportunities to help people with both types of behaviors. But I tell you what, if they get patient complaints and coworker concerns, they are super special.
Yeah. Yeah.
And they need our help in really different ways. And we're likely to recommend moving them further up that pyramid, because there's something going on different in that person's professional life that we need to help, because it's interfering with what we find is that nurse turnover is affected by these behaviors. 40% of nurses who leave their jobs do so because how they were treated by others.
Interesting.
And we've published studies that show that if you intervene at the sort of the system level with nurses and physicians, it actually drops nurse turnover. And how much does it cost us to hire a nurse, right? $60,000+ a person.
Yeah, we don't want turnover. Actually, we have very low turnover of nurses, and I think part of it is the eye care values. Yeah. But this is super fascinating for me to listen to you. You told me that you had a personal story about how safety and quality of care is influenced by interaction. So share with us.
Of course. So I've done research in this space for several years, and then about probably 10 or 15 years ago, my dad, when he was 80, was admitted to his local hospital with a small bowel obstruction. And my surgical friends tell me, an 80-year-old who's had several abdominal procedures and is has other frailties, you don't want to go near that, because that's a really difficult surgical case. So you do everything you can to avoid operating. He was so sick, he spent 56 days in the ICU.
Wow. And
what mattered to my dad in that case, and to my family, wasn't the fact that he had technically competent surgeons. It was the fact that when I went up there on a Friday afternoon, these things happen on Fridays, right? Flying up there on a Friday afternoon, and I got there about 10 o'clock at night. They walked out and they talked to me, and they were respectful to my dad, and they were available to answer my questions, and they modeled teamwork, and they were aware of how the behaviors affected others. And that's what being a professional is. Because 54 days later, my dad said, I'm ready to go home. And 2 days later, he walked out of the hospital and lived another 15 years.
Wow, amazing. Amazing story. And I think these stories shape us. And everyone has, a story like that. How you were treated well, how you felt respected, and how you felt that your entire team is on the same page.
Absolutely.
So, Dr. Cooper, I would like to ask you the final question that I ask every one of my guests here, which is, what does quality mean to you?
So quality means to me that the really great intentionally designed systems we put in place, the people that work in them, all work together in the right way, and that we leave our patients better than we found them.
I love that. Everyone gives me a different answer, and you're the only one that said we are actually better than we have started. So, patients are here. We actually have a better either patient experience than before, or better outcome, or just everybody feels better. Yes. So, Dr. Cooper, I very much enjoyed our conversation. Thank you. And thank you for listening. So that you never miss an episode, subscribe to Quality Time. New episodes will download to your podcast device. I appreciate your support. Thank you, and until next time, I am always listening.